All right, good evening, everybody. I think we're going to go ahead and get started. First of all, I'd like to welcome you all and thank you for coming out tonight to um, a discussion on building trust in healthcare, brought to you by the Student National Medical Association at WashU School of Medicine. My name is Ife Afedaba. I'm a second year medical student and the co-president of the Student National Medical Association at WashU.
My name is Michael. I am a second year medical student as well and SNMA secretary. And we have one other SNMA person on board here.
Yep, my name is Ian Reedy. I am also a second year and I am the other SNMA co-president.
So before we go any further, I wanted to make a statement to honor the communities that have lived on this land before us and from whom we are beneficiaries. So we begin by acknowledging that we gather today on the ancestral lands of the Osage, Miami, and Sioux peoples who were removed unjustly, and that we in this community are the beneficiaries of that removal. We honor them as we live, work, and study here at Washington University School of Medicine. So I hope you guys are all well situated and ready for an engaging discussion. Again, thank you for coming to this webinar tonight. Michael, I'll turn it over to you for a little bit of context and a primer on what we'll be discussing tonight.
Yeah, so thank you, Ife. I'm just going to briefly go over, what we had in mind for these panels and just a bit of the background surrounding them. So, in the wake of the COVID pandemic, medical mistrust is amplified in the public conscious, with many communities in St. Louis experiencing a history of generational injustice, implicit bias, racially discordant care, disparities in healthcare access, and inadequate access to health education. We understand that current and future providers have to work to promote awareness, transparency, and equitable action for those we care for. So for this reason, and with the support of the WSIM Office of Diversity and Inclusion and the Office of Diversity Programs, WashU SNMA is hosting a two-part panel series on medical mistrust. This first panel will focus on the lived experience of patients and patient-facing providers who can speak to personal experiences that have led to breakdowns in trust with the medical system. This is a platform for community voices to be amplified in the broader medical community. Our hope with this panel is to provide a space for tangible insight into community perspectives surrounding the healthcare system and where fault lines have established themselves. We're also going to have a second part to this panel series, and that's going to be on Thursday, September 14th at 7 p.m. And that's going to feature regional and institutional leaders that are going to speak to initiatives that are planned or currently being implemented to address these issues in St. Louis. Actually, we're hoping for you all to submit some questions for us as well so that we can feature them for the panelists to discuss, and that's for the second panel. So we're going to send a link in the chat, so feel free to use that to submit questions, and we're really happy to hear from you. So yeah, without further ado, I'm going to send it over to Ian, and he's going to introduce the panelists and the moderator for today's panel.
All right, so I will be introducing our first panelist, who will be Ms. Robin Cole. Ms. Robin Cole is a lupus warrior, patient advocate, and educator. She received her master's in school counseling from Lindenwood University and a bachelor's in psychology from Southwest Baptist University. She worked as a teacher for the St. Louis County and Hazelwood Public School Systems until 2012. She currently works in the community health space as a coordinated entry case manager for the St. Patrick Center, a community organization that links St. Louis homeless populations with sustainable housing, health services, and employment opportunities. She additionally serves as the Vice President of the Regional Health Commission's Patient Advisory Board. The St. Louis Regional Health Commission is a collaborative effort of St. Louis City, St. Louis County, the state of Missouri health providers and community members to improve the health of uninsured and underinsured citizens in St. Louis City and County. It is led by an appointed board of commissioners and 3 peer-elected advisory boards of institutional leaders, healthcare providers, and patients. The RHC gathers input from these leaders on a monthly basis to advance their mission. So thank you, Ms. Robin Cole, for joining us, and I will be handing it off to Michael for the second panelist.
All right, 1 second, guys. All right, so our second panelist is Ms. Atara Estes. She is a community health worker, author, holistic life coach, educator, public speaker, advocate, and leader in the social justice space. After having survived a harrowing domestic violence episode in 2002, she dedicated her life to serving her community through addressing the social determinants of violent crime, reframing the problem as a public health crisis. Since 2016, she has served as a community health worker through the Reentry Community Linkages program hosted by the St. Louis Integrated Health Network, a program focused on assisting the justice-involved population in navigating through and connecting with health and social services. She served as a crime victim advocate through the St. Louis County Domestic Violence Court and an educator on dating abuse through the Break the Cycle. Atara also serves as president of the Community Health Workers Association of Missouri and is a founder and current board member of the STL Community Health Workers Coalition, which serves as a convening table for community health workers and affiliates to strategize and discuss community health equity. Atara served as co-chair of the HEAL Healthcare Access Partnership table that drives regional community health worker work by scaling and maintaining community health workers in the St. Louis region. She continues to be a member and works closely with the policy committee. She is additionally a current member of the COVID-19 Regional Response Team Steering Committee, which ensures that the strategic directions of the RRT aligns with community priorities and needs. Atara is also a member of the American Public Health Association, where she co-chairs their policy committee's community health worker section. Atara Estes additionally serves as a youth and community consultant for Alive and Well, a local community wellness organization. Now, Ian, if he is going to introduce the next panelist.
So our final panelist for tonight is Ms. Naya Sumpter. Naya is a sickle cell warrior, a distinguished patient and community activist, a scholar, writer, and a full-time student in a health communications master's program at St. Louis University. She received her BA in African American Studies from St. Louis University as well. Naya Sumpter's experiences as a sickle cell warrior have been a key driver in her scholarly and community interests. She currently serves as the chair of the Regional Health Commission's Patient Advisory Board, where she represents and advocates for under and uninsured patients, excuse me. Naya Sumpter additionally served as an AmeriCorps Vista, where she worked with Generate Health and SLU faculty, including VP of Diversity and Community Engagement, to promote equitable health and community outcomes. Naya additionally served as a board member for the Charles Drew Committee through the American Red Cross, where she and her colleagues received the 2018 Spirit Award for their dedication to advocating for increased diversity in blood donation.
All right, thank you all of our panelists for coming. I will now introduce our moderator. Our moderator for this panel is Ms. Kaytlin Reedy-Rogier. She received her master's in social work from the Brown School of Social Work at Washington University in St. Louis, and is currently the program coordinator for the Pipeline to Compassionate Care project in St. Louis's Integrated Health Network, as well as works on the Curriculum Design Committee as a faculty member for the Health Equity and Justice thread of the medical school curriculum here at WashU. She is passionate about trauma-informed care and social justice in the healthcare space. So thank you for joining us, and I will now hand everything off to you.
Thank you, Iffy, Michael, and Ian. Really appreciate it. So this evening, we're going to spend some time having some conversation with these amazing panelists. We're going to start with them by sharing their personal stories. We'll take about 10 minutes each, and I will try to keep us on time so that we have plenty of time to transition into some questions. We have some prepared questions that we'll ask them. And then finally, we will ask the audience to submit any questions you have throughout through the Q&A function that should be at the bottom of your screen. Please feel free to engage in discussion in the chat, but please direct all of your questions to that Q&A so we can keep track of them so they don't get lost. And then we'll conclude at the end. Again, please feel free to submit those questions. And if you have questions that may lead into the next panel on the 14th, feel free to add those as well so that our student leaders here can keep track of those. So without further ado, we'd like to turn it over to our panelists. And maybe we'll start with Naya. If you could share with us just your personal story, what brings you to this panel tonight, and why this conversation is really important to you.
Well, I've been introduced as Naya, and I wasn't born here in St. Louis, but I was raised here for most of my life, and I was diagnosed with sickle cell at birth, and basically I've been under BJC care since I've gotten here to St. Louis with sickle cell disease. And my first few interactions with doctors here in St. Louis were very rocky because even in pediatric care, doctors have a good instance of always trying to predict life, even though, you know, they practice medicine, right? Not you participate in medicine, so you are not the controller of medicine, right? You participate alongside it, so you do things to hope, you know, you can change the route or the course of this person's life, but it may not always work out that way, right? They were always saying how they expected me to pass away so soon in my childhood, and they kind of got my gears rolling immediately. Like, who are you to say or predict somebody's death? Like, you may, you know, have some input about the challenges I may have in life, but how dare you try to say I may die, regardless of what my circumstance is at this moment. So I've always seen myself as a warrior or a fighter, not just fighting against kind of a disabled body, but fighting against the institution who labels me with this body as being dysfunctional, right? And I had a really kind of turning moment happen at the end of my pediatrics, kind of transitioning into the adult world, where doctors did not understand what I was trying to articulate about the type of quality of life I wanted to have. And so in that moment, I vowed to do more than just be upset, but to be an actor, to be active in this change, right? And so I headed off to college initially with the thought of wanting to be a doctor and majoring in biology, but I found another more direct route, and I took up investigative medical science. However, my eye was not necessarily attuned to how racism shows up in the scientific discourse, or yet alone the medical discourse, until I had a face-off with a teacher who wanted to parade around a problematic historical figure. And after having an exchange, I then switched departments to African American studies, and I found a minor in medical humanities. And essentially, I integrated these two humanitarian disciplines to be able to study kind of the history of scientific racism and the discourses of what racism looks like in the different fields. And that's where I am now in my master's program, studying communication with an emphasis in health, crime, and social justice because of my lived experience.
Thank you so much, Naya, for sort of sharing that journey and what brought you to us tonight. Looking forward to hearing more from you. Ms. Cole, could you share with us your experience and what brings you to this panel tonight?
Hello, everyone. Thank you so much for joining us. I can start off by saying, as a child, I was not sick at all, did not have frequent visits to the emergency room or doctor's office. So at the age of 17, when I started having pains, I just blew it off. Figured eventually they would go away, but they did not go away. So I ended up having to go to the emergency room. Not having any experience with speaking with doctors, I went back in the room to see the doctor. The doctor asked me questions, what was going on, and he gave me a prescription. That was it. The medication did not work. So by the end of the week, I saw a pediatrician. He listened to me, he ran some tests, and I was given the proper diagnosis. Fall ahead to the age of 25, again, I was having physical issues, did not know what was going on at all. So I had to again go to the emergency room. And there in the emergency room, the doctor asked very few questions, said, oh, this is your issue, go see the specialist and they'll be able to take care of you. So I went to see that specialist and he said I did not need to see him. He said, you have this, and he gave me another diagnosis, which turned out to be the correct diagnosis. So those two experiences with doctors frame my history of not really trusting doctors because they don't really listen to you. They don't understand what's going on. They don't ask the appropriate questions. So in 1991, I began having physical pains again and frequent trips to the emergency room. They didn't know what was going on, ran tests. And eventually in 1992, I was diagnosed with lupus. And I've heard from many lupus warriors that it takes years to get the proper diagnosis. It just depends on if you go to the right doctor who listens, who has compassion to you. Then in January 2018, I had a heart attack and a stroke. The stroke affected the part of my brain that controls my vision. So they told me that I had double vision from it, but there was something else going on. I was not able to do simple things like place a cup on a table or place my cell phone on a table, but none of the doctors told me anything. Then finally, one doctor said the stroke affected your depth perception. And this was months down the line. I was thinking to myself, okay, why didn't any of the doctors see this, or why didn't they tell me this? So my history hasn't been great with doctors. Yes, I've had some doctors who have been awesome. But overall, whenever I think about a doctor, I think about the history and how it began. So I'm excited to be able to talk to you about it more this evening. Thank you.
Thank you, Ms. Cole. And finally, last but not least, Tara, if you could share with us what brings you to the panel this evening.
Good evening, and thank you for having me. And my story is one that has been told 19 years ago, will be September 13th, when I survived being blindfolded, shot, and left for dead. And with that situation on a domestic violence journey, the survival became a strong will to live or to die. For me to survive something, I still have the bullet in my chest cavity. They can't remove it. As a reminder each and every day how gracious the other two panelists survived through what they've gone through, that I'm here surviving, not only surviving today, but thriving. In the list of things that you all shared about me, I don't look at those things to see how far I've come from. And that I can just say, it's a will to live. I had to go through raising two daughters after that ordeal of my own mental health being challenged, criminal justice aspects, we had to go to court, and dealing with a lot of fear factors, triggers, and for years of fighting through how to come out whole from a physical and emotional setback is really having a strong will to live. I had to help my daughters, who are now young adults in their own right, and I'm so thankful to be able to see them today become the women that they are, the young ladies that they are, and the women that they are about to become. But to know that they fought with the emotional witnessing of what their mother went through. And so they went through emotional trauma and had different mental health issues coming through life. So with that, I had to attend and seek help, outside help, not just for myself, but for my children, because my children were my world and always will be my world. When you have to fight to save yourself, that's one thing. But when you're fighting to stay alive for your children, it's another thing. When I had to get my daughter, my oldest daughter, diagnosed for different things that she was experiencing growing up, it was hard for me to let people in to help me, because I was always frightened that someone's going to take my child away, and that's dealing with family court. And then when you're dealing with allegations of abuse and different things, you're trying to figure out who is protecting whom. I'm trying to come and get help for my daughter for something that no one can actually see, that we have a root problem that made her remember certain things that she can't seem to heal and get through. So we had to seek out for help. And it was hard getting people to look at you as a human being for a very long time, knocking on doors, trying to get help. And it takes months to get someone evaluated and to get treated for the care that they're going to need to get them stable. But I advocated for my daughter, like I advocated for myself to get well and to be where I am today. I'm proud to be a community health worker, because without me going through the experience that I went through, this right here where I'm at wouldn't be there to even talk about, because that means I would have given up. I didn't give up. I'm not going to give up. And there's so much community members to take from each and every one of our stories, to know how to build out their own strong will, and some of our system to come together to allow themselves to help another human being than to charge a human being for something that they couldn't help. So I will be able to share more throughout this time of my work and experience. Thank you.
Thank you, Atara, and thank you to all three of you for sharing those stories. So we want to pivot to some of these questions and really unpack, what does trust look like? What does that mean? How vital is that in our community? And so in whatever order, whoever feels like responding, what does trust look like? What does trust mean from your perspective when you think about medical institutions and the healthcare system in general?
Well, I will go. Oh, go ahead.
Go ahead. You're fine. Go ahead.
Ms. Cole, it's all you.
Okay, for me, trust begins when I walk into a facility. It's a facility neat and clean, or staff assisting patients, or are they standing around? You know, a lot of times I can go into a place and I see staff talking about what they had for dinner or what they saw on TV, and there's tons of people just sitting waiting. So trust for me begins when I walk into the door. Trust is not having to sit 1 and 2 and 3 hours to wait to be seen, and then going back into the exam room to wait for another 45 minutes. The doctor's time is important. My time is important to me. Even if I don't have a job, my time is important. And so trust begins from the beginning. And then when I'm with the doctor, is he allowing me to explain what I'm feeling, what I'm going through? Is he repeating back what I'm saying to make sure he's understanding me? Is he ordering tests, lab work, whatever, trying to help me determine what's going on and what's the best route to solve this issue? So trust begins from the beginning and it goes all the way through with the doctor. My time being important as well as his time, staff being professional no matter the circumstances. And trust is a very, very, very big issue for me, because I expect trust from the medical field the same way I will from anyone that I meet. You know, let's be honest. If you don't know what's going on, say you don't know, but say you're going to try to find out what's going on. Don't just put on this, you have on your white coat, so you're going to just put on this mask that, okay, I know what it is. If you don't know, it's okay. I've had doctors say, well, Ms. Cole, I don't know what it is. You stumped me, but we're going to figure it out. So when you tell me that, I'm with you. We're eye to eye. That's with me. That's building trust with me.
Okay, well, I will add on to that as well. I totally agree. And I know that trust is about you loving what you do. I think it comes with the drive of servitude. You want people to trust what you're doing. You have to demonstrate that you're there for the same reasons, and that's to serve the people that you said that you hired for. And if you know that, they will feel that. And they will give you any information that you're needing. But when it is tarnished, then you have to repair and do damage control, because it might not have been your fault. It could be someone that they met with right before they got to you. So you have to know how to de-escalate in a more calmer manner and come in at a place of, I'm here for you. And letting them have a little bit more freedom and what that looks like in the approach that you're coming to, that you're not trying to be abrasive, aggressive, and allowing them to feel. Because we are, as humans, we feel off of one another. We sense that you don't like me. We sense that you don't want me here. We sense that you don't have time for me. And if you come off that way, what response you think you're going to get from the patient, from the client? Now, if they are able to walk away and not fulfill that purpose of being seen, then you just let another human being walk out of that door, adding on more stress, more chronic severity to their illness that you could have de-escalated and allowed them to be stress-free. That's what I think trust is. It's a both and. Which one you want to do? Pick your heart.
So trust, I honestly think anytime a minority, particularly a minority person, is coming into an institution, we should operate off of the understanding that epistemic trust has already been broken due to the historical nature of our groups operating in the country, and to rebuild such trust. It has everything to do with how we handle these people, right? And that looks like, honestly, empathizing and not sympathizing, but empathizing with this person. And I know empathizing can seem very almost impossible to do if you've never and could never be in their shoes to understand what it means to operate in institutions as a minority and as an oppressed individual, but doing your best to try and recognizing that the ways in which people show up are authentic to themselves and has honestly nothing to do with them. And so when we build trust, it looks like listening. It looks like listening not just to respond, but listening to comprehend what they're saying. And if they're having a hard time, bring in another person or a person that is here to de-escalate the situation, right? That is a hard one on how do you build trust. It's really interesting now because I actually met Ify while she was doing a rotation at a hospital or ER that I was in. And it was some of the small things she did to build trust, where it was consistently breaking down, where the communication was breaking down with the providers and just some of the small things she did was validate me and my experience. And she came back and listened and didn't come with particular questions, but allowed me to tell her whatever I wanted to tell her. And she moved off of that information that I felt was most pertinent. So I think those are just a few small things you can start with.
Thank you all. It's interesting, as I was listening to the three of you sort of share that, there were a few themes that really sort of bubbled to the top. This sort of attentiveness, like what does it mean to attend to somebody in a space and being truly attentive, not just sort of phoning it in some capacity. This notion of the words weren't spoken, but what I kept hearing was this sense of being trauma informed, recognizing that you're not working from a place of having already gotten trust, that really you're working towards building trust. And if you sort of own this sort of humility and honesty in the space, right? If you don't know, say you don't know, try to empathize, don't pretend, right? That meet me where I'm at, listen to what I'm saying, really felt like these sort of themes bubbling up. And I'm wondering if any of you can sort of share, Ms. Sumpter, you mentioned this role that Iffy had actually played for you in the hospital. I'm wondering if there are any very explicit examples that you all might have where there was something somebody did that really strengthened your trust in them as a provider.
I mean, immediately right off the bat, what Iffy did for me was the attending doctor came in and mispronounced my name immediately. I corrected him. As you guys see, I do have a thing about my name, and immediately she recognized and honored that space of that's her name. You say it correctly. And then the attending doctor then pronounced her name incorrectly, and she corrected him. I was like, oh, you corrected attending doctors? That's what we doing. And it was like several other times throughout the interaction, even in front of her attending and her supervisors or her precursor or whatever the name is I refer to these people as. Anytime like that they were encroaching on space that was inappropriate, if I did not tend to speak up, Iffy definitely provided the space for either her to insert her experience about how that's inappropriate or encourage me to speak up, because she recognized the nonverbal cues in the body language of what uncomfortable, like what it looks like to be uncomfortable. Even though you're trying to hold your peace, because consistently as a minority person, right, we always have to deal with being uncomfortable inside of institutions when we're talking about power. But the other thing she did to really hold space and hold my experience was just listening, not interrupting. Small tidbits of, relatedness here and there, but recognizing that this space, it wasn't to center her, it was to center me. So she consistently did things to recenter me in the conversation about what can we do to, empower you, to make you feel better, to speak up and to get the care that you not only, have a right to, but you deserve. And we can see that it's not clearly happening. So how can I, further help that situation? And yeah, she did that to the end, because her higher ups, no, they were not good.
Thanks, Naya. Robin or Atara, either of you have maybe an explicit example of what someone's done to help build trust?
Well, when I was thinking about that, I was thinking about went to see a new rheumatologist. This was my first time going to see her. And she said, well, sit down, Robin, and tell me what's going on. So I began to talk to her. And so she said, well, let's develop a course of treatment. I said, okay, well, let me find a pen. I want to take notes. She said, I have a pen and paper for you. So I began taking notes, and she began talking. The things she was talking about, she also wrote them down. She said, I'm going to give you mine as well. She said, I want to make sure you feel comfortable. We get your needs met. I want to be there for you. And throughout, she was the perfect doctor that I have ever had. She ended up pregnant, and so she moved back home. But every time I went to see her, she was ready to give me a diagram, write this out. She was very attentive to my needs. She didn't hold anything back. If she didn't know, she called in her attending. She was just an awesome, awesome doctor.
And I will share one as I work and do my job with the Relink program, I definitely find myself in a very empowering my community members. My community members that I work with are 18 or 26-year-olds, and they are still in a transformation and transitioning into full adulthood of responsibilities that they have to take on now, that they probably didn't get those life skills, growing up. And I nurture that. I go in and equip them to understand this is your benefits. These are your rights. It's not for what just the doctor want you to take and do. It's for you to ask the questions and research it yourself. And when they begin to question, like, I can ask the doctors, different questions. Yes, you can. And if your medications are not correct, you have a right to let them know this is my experience. I'm having side effects. So they can begin to feel comfortable and confident in being able to talk to their doctor or to that nurse to let them know what are their shortcomings. And when they saw the little wins, I call them little wins, but they really big, powerful wins, their confidence exudes to where they can definitely stay on track for what was next. Good, better, and different it's a process with building trust. It's not overnight, especially if it has been broken. So you're there trying to rebuild this trust, this act of servitude to yourself. Really, you're trying to let them know, hey, I'm trustworthy of what I'm telling you. You can trust me, but trust by your words is nothing. It's all about actions. And I think by the providers listening to the community members, the patients, however way you want to address them, it says a lot in the response of correction of your name or any other aspect, the education because it's too strong. They have to listen and they should be honoring. And if they are not, that's a whole different subject, but we know how that can go too. So that's how you do it.
Thank you all. As I was, the thing that resonated with me most in this is the sense of sort of thinking about yourself as an ally, right? We that I think sometimes medical providers often only think of themselves as service providers rather than this sort of ally or relationship piece that includes this sort of clear communication, thinking about reading those nonverbals and the sort of show upness that I'm hearing from all three of you, that it's a sense of being there when the expectation is that you're going to be there, which seems really, really important. On the flip side of this, what have been some of the most distressing experiences that you've had with healthcare providers, and what made them so distressing?
For me, I can remember going to see a doctor. It was my first time going to see him, and I had my questions ready, what I wanted to talk about, what I wanted to ask him, why was this happening? And he immediately came into the room and started talking. And he just went on and on and on. And then he said, I need to step out for a moment. I'll be right back. He stepped out and never came back. Next person was the discharge nurse. I'm like, okay, I don't know what happened. So my next appointment, I was ready. When he comes in, I'm going to start talking. He came in and immediately he started talking on and on and on. And I was thinking, okay, I'm not going to let him leave till I say what I need to say. And I need to bring up what he did at the last visit. He said I needed to order some labs. He stepped out, never saw him again. Needless to say, I did not go back to see that doctor. But how can you, as a professional, be so rude and not allow me time to talk? Not allow me to tell you what's going on, not you just going in saying, well, your results show this, this, and that. Let me talk. I know me, I know my body. Give me a chance. But to be so arrogant to not even say bye or I need to go to my next patient, I received nothing. He just walked out of the room. So that was just so upsetting to me that he would think that that would be okay. And I never saw him again. So if I were to ever see him, I would let him know that was horrible. You never do you don't do anybody like that. If you're in a conversation with someone, you don't just walk away. So that was very, very disheartening for me.
I'm just sitting here trying to think of just one experience in particular because I have a plethora of experiences that have been traumatizing and disheartening. But I mean, one that really comes to mind, and particularly with the power dynamics that I consistently have to battle with, was I was an inpatient at Barnes Jewish Hospital on Kings Highway, and essentially, I had been hospitalized for a pretty severe vaso-occlusive crisis, and the doctor comes in, and I explain to him how my pain is not being met, and he accuses me of being a drug seeker. And then I basically rebuttal to him how that's inappropriate, and I have given no other signs or signals for him to accuse me of such heavy, weighted words, and he interrupts me with the wrong name and calls me like Lakeisha or Shakana or just like a real ethnic name. And I'm like, excuse me, sir. Maybe you don't understand that this doctor-patient relationship is supposed to be a two-way street. You share knowledge, I share knowledge, and we communicate and convene at the intersection of both of our opinions to then establish a well-thought-out treatment plan that I can now move forward and accomplish my goals in life and have a good quality of life. Maybe you missed that part, but sir, let me reiterate that for you. What you just did was very inappropriate, and now I want to dismiss you from my care. And I'm trying to say all of this while policing my tone. Very difficult, right? Because there are other cultural signs and signals that, you know, if you give off and make power uncomfortable in your presence, then you just automatically dismiss your chance of, you know, talking with this power. And so basically, I dismiss him in a effort to de-escalate this situation. They send in a black, I guess, charge nurse or whatever. She was really just black. That was the only thing qualifier she had to be coming in my room and trying to de-escalate the situation. And I just thought it was just wow, so funny. In the same system that this, like in the same breath that this system tokenizes you, you're going to come in here and tell me that this is not a problem and that this doctor made a small mistake. So what does it look like when he makes a big mistake? Are you just going to swipe that under the rug as well? Like, you know, you're dealing with a life. And while you may see him naming me or giving me the wrong name as a small mistake, that's a very big mistake, because then he could confuse my patient file with whatever patient name he confused me with and put my life in danger. If not, he has not already done that already. Like, because you don't know what that psychological verbal abuse landed on me, how it landed on me. Like, who's to say that I'm not mentally distraught after having a conversation with him? And now I am ready to do something unthinkable, but I would never again admit that to y'all. But still, that these are things that need to be thought about and said very carefully every time you interact with the patient. Your words have enough power to land on somebody incorrectly, and you could cost them their life. If not physically, verbally, you can do that and cause somebody else to really think they're low about themselves. Like, there's been a multitude of experiences I've had just as a sickle cell warrior, not even being black, not even being a woman, not being queer, just being straight up a sickle cell warrior, that have been traumatizing in itself. Tend to not trust healthcare providers just off general preferences. Very traumatizing, just in general, having sickle cell disease. Before we even talk about the health ramifications of sickle cell, just interacting with the institution on its own merits is traumatizing in itself.
I would share, how would I say this? Cultural differences. My daughter had to have, I can only use her as an example because I witnessed her going in and out of the hospital, being in high school, for her mental health, and the different uh, reactions, reactions she was having with the medications that they were trying to put her on. And just looking at doctors just prescribing one medication after the next and sending you home with a 16, 17-year-old child who is going to go through something in order for the medicine to begin to work. And one thing I can say that they don't prepare the caregiver for the experience that they're going to have before the medicine begins to work, if it ever works for them. And to know that you have to witness your child almost dying from homicidal aspects because the medication is making them feel irate, psychotic, to almost lose your child more than one occasion from doctors' recommendation of medication. And I'm trying to let them know this medicine is not working and you're going to have to do something to change it. It became a really bad nightmare and almost became one that I'm glad I don't have to say that she did not turn out well, because today she is doing well. Medication or not, you have to be attentive to that patient, and you have to be supportive to understand that it's not a one size fit all with the medication that you're prescribing for individuals. It's a hope that the medication will work. But to tell them that they're not taking it correctly is an insult to the person who is looking and monitoring that they are taking it and they're having adverse effects. And only to come to find out that she was allergic to all antidepressants. So who was making it up to only find out that they are allergic once they had another professional doctor to say they cannot take it? I was looked at as the parent who wasn't complying to give my daughter what she needed. And I was looked upon in such a manner that it could have ruined my career of work or anything. Just me as a parent taking my child away because she is reacting differently on medication that I can't control. No one can control someone who is not on the right medication, period. And it's not a one size fit all. So that distrust is very real. And when you have a mistrust like that, you have to repair it some way, somehow. So I have a smile on my face because we worked through it and we will continue to work through it, because she's old enough now to advocate for herself in this arena, to know what works for her and what doesn't. So.
And I also want to honor in this space that it's not just medical mistrust, it's generational mistrust for a lot of us. And some of us feel it a little bit more heavily than the next may. So it happens. I recognize it is not nobody's else burden to maybe rectify that, but in some effort it is when we start talking about the systemic things we see happening in our community. It is because we've generationally been abused and we've held that trauma of our ancestors.
I think that's such a good point, Naya, around the role that our identities play in it. And you know, as we talk about this in medical education, that it may not be anything that any one provider has done, although from what I'm hearing from you all, that sometimes it's these things, like the most disheartening things are things that should be sort of a common courtesy, right? Using the right name, saying goodbye, right? Like these things that you know, I think now you sort of spoke to this, like, if this is a small thing, then what is a big thing, right? Because it's the compilation of a bunch of these small things that says, like, you're not even treating me like a human right now. Like, I can't imagine what an outrageous thing would look like, because you're willing to do these things that sort of dehumanize. And to your point, Naya, right? Like, how do these things then compile over generations? How do we start to hold that burden? And I'm wondering, it's been spoken to a little bit. Can we explore that notion of what has the role of really like discrimination and identity played in how you think about mistrust, particularly in healthcare?
Wow, that's a good question. It makes me think about, I was in the hospital. It was a heart attack, and the doctor came in and he said, how many cigarettes do you smoke a day? Not if you smoke. How many cigarettes do I smoke a day? I've never smoked a day in my life. So I'm looking at him like, how can you just ask me something like that and you don't even know me? So that just, it just blew my mind that he would ask me that. And then at another doctor's appointment, my doctor had not released me to return to work. So this particular doctor asked me, well, how do you go about your day? How are you able to work? I said, well, I have not been released to go to work. And he said, so are you living off the government? That was a big shock. I was insulted. If I was on public aid, whatever my income would have been, it was okay. But for him to just say, are you living off the government? That was an insult. He could have worded it differently. He should have thought about that question before he asked, but there are people who are on public aid because they cannot work for physical or mental health reasons. So it should not be looked down negatively. So are you living off the government? Both instances, those doctors were just totally off the mark. I don't know if doctors are required to take classes. I won't say class because they need more than one on customer service, empathy. They need to take them all because a lot of them are missing the mark. A lot of them think I've earned this degree, so I should get the respect and I can talk to you any way I want to. No, you cannot. You're a human being and so am I. So respect goes both ways.
Can you repeat the question again, please?
Yeah, so we've talked to this a little bit, but what has the role of discrimination look like as it relates to sort of identities that you hold, particularly in healthcare, Ben, and how has that impacted your sort of perception of trust?
Well, discrimination in terms of identity looks like I was alluding to it a little bit earlier with sickle cell disease, is the immediate distrust when it comes to allotting narcotic drugs or believing that we are in need of such drugs, because the severity of our disease cannot necessarily be denoted by just these signifiers, these easy signifiers that people may, signify for what looks like pain. Recognizing that I'm Black, so I have generational pain that I'm consistently dealing with and burdensome with. So my pain does not show up the same way. Whereas, no offense, a white woman or a white person, they have obvious signs of unable to deal with such a huge load, whereas mine would not seem as severe, even though the pain is very, very severe, right? But I won't necessarily be crying and doing these things because I've had to learn how to adapt very young about distraction and coping mechanisms. Even if something is bothering you, you have every right to feel your deepest, feelings around such said topic, but you still need to know how to cope and adapt in this world, because you Black and you're a woman, so you already are coming with two strikes against you. Recognizing that I always, to be as good as a white person, I have to be 10 times better. That is consistently repeated to our young generation. To even be seen as competitive, we have to be 20 times as better than our peers. So so discrimination for a Black sickle cell warrior is consistently, regardless of what our labs signify, is not believing anything that we're talking about. It looks like accusing us of drug seeking because we have weird patterns of how we use the healthcare system. And one particularly is, why did you go to so many hospitals? Because these 2 hospitals immediately treated me wrong. So we didn't even make it to as far as drawing blood. I left because I recognize I don't have to deal with that. And that's why I'm here right now. And it looks like I'm about to leave again. Number 2 is like, why didn't you go to your healthcare provider? Why did you use the ER? Because the clinic and my healthcare provider is only open during work hours. I'm not allowed to miss any additional days, seeing as I already have extended amount of days I missed because of hospitalizations. So I'm utilizing your ER at 2 a.m. because I still want to keep my job at the end of the day. When we know, jobs is a whole nother conversation of how ableism shows up in the workforce. And doctors not having or not being attuned to any of these things and making and using them as markers of, discrimination or ways to look at this patient as being less than deserving, when that's not even what's happening here. And ultimately, one thing that I explained to Ify, you realize if I just wanted to abuse drugs, I have easier outlets to get access to the very drugs you're giving out here. I don't have to put myself through this dehumanizing abuse. Like, I'm trying to be, appreciate and accept the rules and go by the rules. But consistently, these rules are looking very arbitrary when we see other people, especially white cis heterosexual men, are allowed to break it and there's no consequences yet. I just had an experience where it led to charges being filed against me, and I never even got care. I never even got care or received care from this place. But this place immediately tried to call the police, and the police, because of the area that I was in, believed them over me, and that's a whole nother issue when we talk about discrimination. Discrimination shows up as authorities looking and believing and putting epistemic trust in the providers and immediately, giving epistemic injustice to the patient as if the words that I'm saying are untrue, have no credibility. They're giving me a deflated sense of credibility if they are extending just a little credibility to myself, right? Discrimination just ultimately comes off as epistemic injustice, is that deflated sense of credibility to what I'm saying because of the identity that I represent, right? So being a Black woman, my pain is even more invalidated because because of the societal trend of women tend to over exaggerate pain, when in reality, our lived experience tells us men tend to over exaggerate their pain more than what women do. Like, yeah, whole tangent, how can I give birth to an entire human and still stand after the bed? Like, right, our pain is very, very valid and very real. So discrimination just shows up in a plethora of ways, but those are just a few.
Well, I would say how it shows up, as I am an advocate for domestic violence, I'm an advocate for social justice, I'm an advocate for mental health. And the discrimination that comes to all 3 is that someone is a victim. There's a victim somewhere because someone is taking authority and trying to use their power to crush the other individual, to make them not feel as equal or can be and partake in whatever role that is in life. I know that for what I do with working with my community members with Relink program in the criminal justice space, it's a lot of discrimination going on because majority are Black men and women who I serve. And when you take in on those caseloads, you're going to represent them and assist them through whatever that is to navigate, whether it's clinical or non-clinical aspects. And they're already labeled before they can even say anything, due to the fact that something may have happened to get them in that situation. I'm going to use mental health as one of my main focus, is because a lot of people And when I say a lot of people in the criminal justice space, depending on who we're speaking of, rather it's the police, rather it's the correctional officer, rather is anyone. So I'm not leaving no one out. If someone comes in your space and you have to apprehend or you have to assist them in whatever this is, you already got strikes against them. That stereotype is already there. No one even look at maybe it could be a mental health issue. They already looking at, we're gonna pronounce it as a drug issue. And not everything is a drug issue alone. Sometimes these things go undiagnosed for a dual diagnosis. And the reason why they probably would be on drugs if it is stemming from mental health is because they're trying to cope with what their pain is, because the medication that they're on is too strong and is not leveling them out. Now, this is still not a one size fit all, and I'm not here to bash the healthcare system on that, because we have a responsibility. And I'm going to say we as Black people, Black community, we have a responsibility to educate ourselves, to make sure that we know what is going on with us. Because if you let someone else tell you what's going on with you and it's wrong, it's because you haven't said anything different to go against what someone else is assuming that could be the problem that is going on. You know more than anybody else. We have a taboo that's in our community about mental health, and no one really takes on the importance of understanding it does run strong in some of our families. It definitely runs strong in mine, that a lot of people don't want to talk about it. But I talk about it every chance I get, and there's no shame to talk about myself, to talk about my daughter, or any other family member that I advocate and assist with. So we have to begin to look at ourselves, educate ourselves, and let others opt in to want to share that about themselves. See, that's another thing. Can I tell you what is wrong without you assuming that that is the problem? We have to change up the dynamics, and then we can kind of be able to share an understanding of how everyone is going to be different, and how we receive and how we comprehend. Everything is going to be different for each person.
This notion that our identities often become barriers for communication, that folks are making assumptions or they're not allowing, right? I know myself best. We have to sort of do our own work around ourselves, and for our providers to allow space for that advocacy to happen, I think is really, really important. And really thinking about how can we create spaces where our identities aren't barriers to communication, but rather we're actively working to make sure that we're able to facilitate conversation through identities, right? Leaning into that. What does it mean to have conversation through this? Even as a white woman, how do I approach a situation if we don't have shared identities? I think is a really important point. Ian put in the chat for our participants this evening, please remember to utilize the Q&A function so that we can get some questions for these wonderful providers. I have a few more questions I want to pose to our lovely panelists before we move into the sort of audience portion of this. I wonder if you can, switching gears a little bit to thinking about, so we've talked a lot about distrust and all of the factors that sort of fold into this notion of distrust and the role of identity, the role of this generational trauma. I wonder if we can talk a little bit to what it has looked like where you or organizations you work with. I know we've got some folks that work with the RHC, IHN, those kinds of places. What does it look like to successfully garner trust? What is that meant? And what are the skills and tactics we can use to effectively garner trust in our communities?
For me, when I hear that question, it makes me think about the pandemic. When the pandemic first started, there was testing out in the areas where more of the population had health coverage, more of the population was high income. There wasn't much testing going on in St. Louis City or North County with the where the population was below poverty or people of color. So different organizations saw this and they stepped up and they started doing testing in the city and in areas where people can get to easily on the bus. So it was real shocking to see. When I saw it on the television, I was thinking, wow, why are they only doing testing way out there? And so I'm assuming these organizations saw it as well, and they stepped up and they provided testing all over the city and in the areas in the county. And for me, that showed trust that, okay, this organization is for helping those who are considered below poverty, those who do not have easy access or health insurance. It showed that they cared about everyone, no matter the socioeconomic status. It was good to see that they stepped up and brought the testing to more areas.
So creating avenues for access and making sure that those kinds of things that typically get in the way are no longer barriers is one way that we can help think about what it means to garner trust.
Yes, absolutely.
I'm going to say that I truly believe in collaboration with partners. I think we all see in the same problem. I think we can bring a solution by coming together with our strengths in our own areas to actually, as the community health workers, I have to give us a shout out. You know, community health workers, we take pride in helping the community because we are the community. And when you do that, you find yourself being a neighbor. And I think by bringing everyone together, not because of COVID, I think it brought more of us together because we were left with no other choice. Were we going to let our neighbor die? No. I found more people knocking on doors trying to help with the food pantries, that if they couldn't get there, they brought the food to them. I found us to really be more hands-on and engaging like never before. And were they really frightened by COVID? I'm sure we are. But we just could not let people be there alone. That collaboration that CHW's brought forth during COVID and still moving forward is not going to stop. We're just getting started. So that's what I believe in, how we can make our communities thrive even more. Utilize you at CHW, you know what I'm saying?
Little shout out there. You know, I think I heard this term collaboration. What I really heard was really thinking of yourself as part of the community, right? Like that's the key component to community health workers, is they are part of the community, they're members. And you don't have to be a community health worker to have that same mindset, right? To have that collaborative mindset, to really consider yourself part of a community that you're working in. Even if based on identity, you don't necessarily belong, how do you sort of think of yourself as beholden to or accountable to community? Really great points. Naya, thoughts about this?
Yes. This whole conversation kind of brings me back to the idea of epistemic injustice posed by Miranda Frickner. And to counter epistemic injustice, she talks about epistemic virtue. And some of the things to be a virtuous, like epistemology, I guess, to come from that angle, is to just have some virtues like consciousness, creativity, curiosity, honesty, humility. But I thought one of the most interesting ones was when thinking about the people who have been unjust in my interactions, they often are, I guess, analogous with racists, right? And thinking of this is these people often go in line with what society has said. And so to be virtuous, you almost have to buck the system. So whatever, and I often saw Evie doing this, whatever your higher ups or whoever the way that the system is organized and is currently disenfranchising, you have to be a critical thinker and think outside of that box of why are they placing this patient in such box? And what am I doing to now, just like, what am I doing to try to rectify this situation? Because staying in that box is just going to keep the patient feeling more isolated and in this space of not not believing or trusting us as practitioners. So they might not be being as truthful and as transparent with us. So in an effort to be able to get more transparent with this patient, you do have to be a critical thinker and ask and do the things that society is telling you almost not to do. You need a variation of wisdom and understanding to know when this is acceptable, right? Like, those are some of the things that brought to mind if we were to actively build trust and want to right the wrongs of our ancestors. Not mine, y'all.
That sort of reminds me of this notion of like silence is compliance, right? That if you don't sort of actively engage. So in the interest of time, we do have 2 questions that have been submitted by our participants. So I'm going to start with this first one. And perhaps Atara, you can speak to this first, and then Naya and Robin, if you have some thoughts of weighing in on this. But Atara, only because you brought it to our attention first. How does the Black community help dispel harmful myths in the Black community about stigma, particularly around mental health, but generally these sort of healthcare myths that exist in those narratives, and what does that mean? What's the role there?
Ask that question again, please.
Yeah, so how does the Black community, right? There are these myths that exist. You spoke to this myth around sort of stigma around mental health. What's the responsibility of the Black community to dispel those myths?
Well, like I said before, I think it's better to be educated, research, be a part of support groups, that actually give you more information pertaining to mental health, if that's what we are focused on. There is national support groups, there's regional support groups that if you really want to be about being better and having a well-being to yourself, you have to become more knowledgeable and changing some of the things that we learned growing up. Some of the things that we learned growing up, we thought it was facts. And that was just how our parents and our grandparents were taught. And not necessarily meaning that that's the best way, but that's what they learned. So you can redirect, you can improve your learning, you can evolve in new learning habits. You can break those generational things. Now, I can say this when it comes to the Black community, because we can talk all day about generational curses. And I get it and I hear it. But we are a strong entity of Black people who have generational blessings that we have to know how to stand in it, lead in it, be it at all times, and never take it off. Don't even apologize for that. That's what I really feel, that how we can become a better community for ourselves and for one another is to not only look at the bad that we have, but look at the doggone good and balance that. That bad situation that we may be in doesn't have to be our narrative for tomorrow. We can change, and it has to start with us, you, the individual. And then you can pass it and play it forward and move it forward with the next generation of people that comes into your path.
Thanks, Atara.
I have 2 comments about that. The first one, I would say, if you see someone having a mental health episode, call 911 and ask for the crisis response unit, not the police. Crisis response unit are trained to handle those particular situations. As we all know, if the police come, it can explode into more than what it needs to be. So if you call the crisis response unit, And my second one is about medication. I work with the unhoused, and I've had several clients that have said, well, yes, I was diagnosed with this or that, but no, I don't take the medication. And the reason why, oh, I don't want anybody to know. And I will ask them, well, if you had high blood pressure, would you take that medicine? Yes. Well, why? What's the difference? Well, mental health, if you're depressed, something's wrong with you. If you have high blood pressure, you have a problem inside your body. If you have depression, there's a problem inside your body with your levels. We need to learn how to talk to each other and tell each other it's okay if you're taking mental health medications, if they're working for you. Don't let anyone tell you don't take your medicine or you don't need that. If it's working for you, please take your medicine. And it's been passed down generation to generation not to take the mental health medicine. We need to start generation to generation saying, if that medication is working for you, take it. If it's not, let's find something else that will work for you. The stigma needs to be taken away from taking psychotropic medications for depression, anxiety, whatever it is. If it's working for you, if it would keep you in your own home, keep you employed, then it's the right medication for you.
So in the interest of time, Naya, did you have something you wanted to add?
Oh, I was just gonna say, I do think Black people do have a piece to play in, dispelling some of these myths around um, around like mental health and the other health issues that happen in our community. But in a dichotomy, right, it's all in balance. That in the same sentence, I also appreciate some of the gut feelings that Black people have, and I would say not to discredit those feelings that we have, even if we cannot particularly articulate, around the conversation of mental health or the, vaccine skepticism or all any of these things. We have lived experiences. In particular, we live within a hermeneutical injustice of experiences. So it's hard to begin to even understand whether we should be taking these medicines, because I do have a diagnosis of a mental health illness on my medical record, but I do not take medication for it because I think this diagnosis came out of a culturally inappropriate place, right? And so we have to be aware of everything that medical practitioners or people with authority say is not always true, right? So appreciating that dichotomy, right? We have, like one of my other panelists said, we have trauma, but we also have generational blessings. So I think that just all needs to be kept into perspective.
Thank you all for that. So in the last 5 minutes, I want to just end with this notion of what can we do to rebuild trust, right? So there's a question from a participant around how do you rebuild trust if you make a mistake? And I think we've talked about that sometimes that trust needs to be rebuilt because of someone else's mistake, right? Some other provider's mistake, and that means that med students, new doctors are also needing to do the work to rebuild trust. So what does that look like?
I got it for you. That looks like stop commodifying essential resources, right? There's no reason for healthcare to be commodified and privatized the way that it has been. And if we're truly, as practitioners, looking to make this a more accessible system, I think that is step one, right? Patients should not have medical debt appearing on their credit scores. That's stopping generational wealth from building right there.
That was great, Naya. I agree so much with that. And I also think that it starts when the doctors are in medical school, the doctors and nurses, nurse practitioners, they should have classes. I had a friend who attended one of the major universities here in St. Louis, and all of she said all of her other classmates, she was the only Black one in her class, were told, never go to this part of town. No, it should start in the classroom that do not stereotype. Just because you see I'm brown or whatever, don't just assume I smoke. Don't just assume that I'm not eating healthy. Don't just assume all the males are criminals. It needs to start in the classrooms. Don't say how many cigarettes do I smoke a day. If you're in med school, there needs to be classes where ordinary people off the street are brought in to give you examples of what you should not do. Don't just stereotype all of us into one category. If they one do it, they all do it. So that's what I have to say on that subject.
I would say to help bridge that gap, you need a community health worker. I'm sorry, I just gotta, because it comes to, we are the mediators, and I'm gonna say we come as the mediators in the cultural differences, and sometimes you don't have, that patient may not have the full understanding of the verbiage that the doctor is trying to let that patient know, and vice versa, of where that patient is coming from, that the doctor needs to understand where they're coming from. So having a mediator can really cut down. I believe, this is just an opinion, I don't have no stats or anything, but I have seen, whereas if you have someone that's in between mediating those differences, you can find a common understanding to what is needed and expected from both parties. And I think that's just an opt-in process, but if the doctors or nurses or whoever is the leading provider cannot reach that community member, get someone to mediate. It doesn't hurt. It's not going to break the bank to pay someone else to fulfill a service that you need people to come in your doors in order for you to continue to get paid. So if you want to still work, then why don't you make sure you have quality care for the patients, for the clients, so that you can continue to eat and feed your family, and they're able to eat and feed their families to go home to still see their families. You see, there's a win-win that we all can play. But if we only worrying about one side, I'm just here to do my 8 hours and I'm out of here, then you're gonna see this disruption that we have right now that we presently are dealing with. And we can change the narrative. It all starts with us.
I just wanted to add to my answer, because I know I gave a very systemic answer. Things people or practitioners could do individually is actively divest from these harmful systems that they see occurring. And two, particularly is to stand up and speak out, right? When you mentioned silence is power, speak out against their peers when they're being racist or being biased and prejudiced towards patients. Because in medicine, one thing that they often hold strong to is, oh, I don't like to step on people's toes or their doctor's toes. If he's wrong, he's wrong. Speak up and say something about it. You are actively causing harm to other communities by being silent. So that's really what I want to add to the conversation. We can be better about holding practitioners and people in our cohort accountable.
Thank you all for this conversation today. I really appreciate it. And the honesty and the vulnerability that you all were willing to share. So that I'm going to turn it over to Iffy to close us out.
Hi, everybody. So that concludes our discussion. I wanted to thank everybody in the Office of Diversity Programs and the Office of Diversity, Equity, and Inclusion who helped us put this panel together tonight. I obviously want to thank our wonderful panelists for sharing your experiences and your insights. And I'd like to thank the audience for coming to participate in this and for listening and being part of this discussion. One last thing I wanted to mention was that it would be great for you all to join us again on September 14th, 2 Thursdays from now, for part 2 of our discussion, where we'll be speaking to a few regional and institutional leaders to further this discussion, talk about the experiences of mistrust, and talk about initiatives that our regional institutions are engaging in to help address mistrust in the community. So with that, I'd like to thank you all, wish you all a good night. And I hope we can see you again in 2 Thursdays on September 14th.